So, hello, I am Rebecca Delonzo, and I'll be presenting some of the key findings from my thesis. This is the final presentation for my thesis, low-dose radiotherapy and how it can be used to remodel the tumour microenvironment to enhance immunotherapy. And I would like to thank everyone who's helped, especially my supervisors, Mun, Alistair, and Pejman. So a bit of background on mesothelioma and why it's the focus at NCARD. It's a cancer of the mesothelium, which are the cells that line the heart, lung, and chest cavity. It's caused by asbestos exposure and has a long latency period with an average of 40 years, but can range from 20 to 60. The combination of anti-PD-1 and anti-CTLA-4 immunotherapies have recently been approved as a first-line treatment for mesothelioma. But despite the new treatment, mesothelioma still has the lowest survival rate of any cancer in Australia, with the average survival of 12 months after diagnosis and treatment. So finding ways to improve treatment response, especially immunotherapy, has been the focus of some research. And one of the ways is through low-dose radiotherapy, which involves a small number of fractions of 2 grays or less. Low-dose RT has been found to stimulate a tumour-specific immune response. It upregulates cytotoxic T cells, helper T cells, macrophages, and a whole range of other immune cells. It also increases the expression of leukocyte adhesion molecules on endothelial cells that line blood vessels, and these help recruit circulating immune cells from the blood into the tumour. And this is enhanced by the angiogenic effects of low-dose radiation. Tumour vasculature is highly dysfunctional and irregular, but low-dose RT can stimulate vasculature endothelial growth factors, which then cause the regulation of angiogenic factors and cause growth of blood vessels that are normal and functional. This increases the blood flow into the tumour, increasing the oxygen levels. This then decreases hypoxia and therefore immunosuppressive factors that are upregulated by hypoxia, such as hypoxia-induced factor 1A, 1-alpha. And the increase in blood flow also allows immune cells and immunotherapy to enter the tumour. Researchers found that doses of 1 to 2 grays per fraction can increase blood vessels in tumour models for up to 2 weeks post radiation, and it has the potential to be even longer in patients. So what we wanted to ask, one of the questions for my thesis was to find an optimal low-dose fractionation schedule that alters the microenvironment in mice models of mesothelioma. So to do this, we irradiated subcutaneous mesothelioma tumours with a small animal radiotherapy device. The tumours were imaged every second day post-radiation until day 29 post-inoculation, or the mice had been culled earlier if the tumours had reached the maximum size. So all of the tumour groups were contoured to the largest 25% of the volume. So in the area was found in the transverse plane, and say if the area was 10 millimetres squared, the tumour was then contoured to 7.5 millimetres squared. We wanted to further investigate spatial differences between sort of the conventional 2 gray and some hyperfractionated 6 gray schedules. So additional contours were made, and these consisted of a 1 millimetre diameter circle in the middle of the tumour, seen here in blue, and that extended to that sort of maximum 25% area. And that I've called the whole core. And then another contour, another 1 millimetre diameter circle, seen here in pink, was just the central 11 slices that had the largest area. And this is I've called that central core. So one of the ultrasound techniques used was power Doppler, which images the functional blood flow through vessels. And we have the radiated tumour and a non-irradiated tumour, and there is more blood vessels coming down in the irradiated tumour compared to the non-irradiated tumour. and these had similar volumes. So to analyze the power Doppler data, I created a mixed effect model that was to control for factors such as the group, the area, the size of the tumour, the day post inoculation, repeated mouse measurements, and see how those variables interacted. And we found that the 2 Gray times 4 fractions and 2 Gray times 5 fractions significantly increased the blood flow in tumours compared to the unirradiated controls. 2 Gray times 5 fractions had a relatively stable period of increased blood flow for up to 9 days post-radiation, after which this dropped off. And we compare this to the 6 Gray times 2 fractions, where there isn't much blood flow happening on the earlier days. Then there's a large rise in a peak at day 21 post-inoculation, and then it decreases. And of course, radiation is going to make tumours smaller, and so the increase needed to see if the increase in vasculature was simply due to the fact that the radiation made tumours smaller. And the model confirmed that this wasn't, that the increase in blood flow wasn't due to the tumour size. The 2 Gray times 5 fractions resulted in significantly more blood flow compared to the control for a range of tumour sizes from 5 millimeters squared up to 50 millimeters squared. And something we also found was that the 2 Gray times 5 fractions had significantly more blood flow compared to the 6 Gray times 2 fractions for areas that were 10 millimeters or less. And that sort of also corresponds to the earlier time points. And so when we look at the spatial differences in the blood vessels in the tumours, we see that the 2 Gray times 5 fractions, also in the middle of the tumour, and the very centre of the tumour, had significantly more blood flow compared to any region of the controls. But the 6 Gray times 2 fractions, there was no significant difference between those and the controls. As you can see in the centre core here, most tumours had no blood vessels in the middle of them, and some only had a peak on sort of day 21. We also found that the 2 Gray times 5 fractions had significantly more blood flow compared to the corresponding regions in the 6 Gray times 2 fractions for the core regions. So centre core has far more than this one. So there was big spatial differences between the hyperfractionated and conventional, with hyperfractionated doses sort of leaving the blood vessels more in the periphery. The other ultrasound technique used was photoacoustic, which detects the oxygen saturation of blood by detecting the oxygenated and deoxygenated hemoglobin. And we have the irradiated and non-irradiated tumours here. And we can see that the irradiated tumour has far more red, which is oxygenated, compared to the unirradiated, which has a lot more blue, which corresponds to the deoxygenated hemoglobin. So another model was used to find the significance and compare the range of values, and we found that 2 Gray times 5 and the 6 Gray times 2 fractions had significantly more oxygen saturation in the whole tumour tissue volume compared to the unirradiated. And there is more of a linear decrease in the oxygen saturation over time, as opposed to sort of the peaks that we saw with the blood flow. And this corresponds to the size of the tumours, because when tumours are smaller, so less than sort of 15 millimeters squared, blood is able to get into the tumour via other methods, such as diffusion, not just blood vessels. So those smaller tumours, sort of regardless of which group they were a part of, they still had a level of oxygen saturation that wasn't significant. But once you got past 15 millimeters squared, then there was a significant difference between other sizes and the control. And comparing sort of the peripheral and the middle of the tumour, had a similar results to the blood flow, where the 6 gray times 2 fractions had significantly less oxygen saturation in the whole core and the center core region compared to that whole tumor volume, but there wasn't any difference between the regions in the 2 gray times 5 fractions group. The photoacoustic data can also give the oxygen saturation in blood. So this doesn't take into account the tumor volume and essentially gives the quality of the blood and how oxygenated it is. And we found that 2 gray times 4 and 2 gray times 5 fractions had a significantly higher oxygen levels compared to the control. And there isn't a decrease in the oxygen levels over time, and this indicates that the blood vessels formed are maintaining their functionality. Although the percentage of blood vessels is decreasing as the tumor grows, they're still able to go functioning and able to send oxygenated blood through the tumor. And the 2 gray times 4 and 2 gray times 5 fractions had significantly more blood oxygen levels compared to the controls, no matter what tumor size. And there wasn't any significant difference between the groups or within the groups for the irradiated tumors. So the blood vessels that were there were functional no matter kind of what location they were in the tumor. So to summarize that sort of first section of our thesis, we found that 2 gray times 5 fractions significantly increases the blood flow and oxygen levels in tumors compared to non-irradiated tumors, and also some tumors that had less fractions on different schedules. And the levels were significantly greater across all corresponding time points compared to the non-irradiated tumors. And for the blood flow was significantly increased for all tumor sizes, and only apart from just those few sort of smaller tumors, there was a significant increase in the oxygen saturation in the tissue as well. And importantly, the 2 gray times 5 fractions increase the blood flow and oxygen levels in the middle of the tumor, which is important for treatment, as opposed to the 6 gray times 2 fractions, where increase in vasculature and oxygen was sort of limited to the periphery of the tumor. So we then wanted to combine the 2 gray times 5 fractions with different immunotherapy schedules to try and improve treatment outcomes, again in some mice models. So to do this, we treated mice that had a subcutaneous mesothelioma tumor. Mice received either anti-PD-1, 3 doses of anti-PD-1, 2 gray times 5 fractions, or 3 doses of anti-PD-1 at the same time as radiotherapy, 1 day after or 7 days after radiotherapy. Some mice also received an additional dose of anti-CTLA-4 on the first immunotherapy dose. Mice were treated and monitored. Any mice that were cured of the tumor and had no observable tumor for 30 days, then received reinoculation with the same cell line but on their opposite flank. And this was to test any immunological memory. And so we found that tumors treated with just anti-PD-1 had no significant tumor growth delay compared to the untreated tumors. But all of the radiotherapy plus anti-PD-1 groups had a significant delay in growth compared to anti-PD-1 and also the untreated mice. And the concurrent delivery of treatment cured just around 50% of mice. And none of the tumors, none of the secondary tumors grew. And so only the concurrent delivery of treatment and when anti-PD-1 was given 1 day after radiotherapy significantly improved survival compared to anti-PD-1 alone. The later delivery of the radiotherapy immunotherapy didn't. The addition of anti-CTLA-4 then further improves treatment results, with the dual immunotherapies now having a significant growth delay compared to the untreated mice. And once again, these two groups, the concurrent delivery and the 1 day after radiotherapy delivery of immunotherapy, significantly delayed tumour growth compared to the dual immunotherapies. Something sort of interesting to note here is that the treatment group where immunotherapy was given 1 day after radiotherapy, there was one primary tumour relapse here that occurred quite suddenly. This tumour had been re-inoculated because it didn't have any measurable primary tumour for 30 days. And about a week after the secondary inoculation, the primary tumour suddenly grew, but the secondary tumour didn't grow. So that could partly, the later delivery could partly sort of have less of a strong response compared to the concurrent delivery where all of the mice were cured, as opposed to sort of this little primary tumour that just suddenly regrew. So indicating that the immune response might just be a little less as strong. And that primary tumour relapse also affected the significance. So only the concurrent delivery of the radiotherapy and immunotherapy had a significant increase in survival compared to the dual immunotherapies. And this, looking at the graph, you'd think it would be the other group would be significant, and that is probably influenced by mouse numbers as well. So because of those incredibly high cure rates, which were a bit unexpected, great, but we then tested it in a different cell line, the AE17 mesothelioma cells. These are more treatment resistant to radiotherapy, immunotherapy, and chemotherapy. And unfortunately, they do have a somewhat unreliable growth. So we had aimed to treat 10 mice per group, but we only ended up with 5 mice due to this. So keep that in mind when looking at the significance and the results. While they're not as strong as we would hope for, but there's still some important sort of information that we can see from the results. So the anti-PD-1 and anti-CTLA-4 alone, they have this varied response. As you can see, some tumours did not respond at all, some sort of responded, and few had great response. And this reflects what's observed in the clinic, where you have sort of no response, partial, and a great response. But importantly, what we saw was that the combination of the radiotherapy and the immunotherapies consistently delayed tumour growth. So especially compared to the other groups, so the other treatments. So this, I guess, is more realistic of what you would sort of see when you would apply this into patients, that you're not going to have those wonderful 100% cures, but you will consistently improve the treatment response and delay growth. And so unfortunately, also partly influenced by the numbers and the resistance, we didn't see any significant improvement in survival for the radiotherapy and the immunotherapy group compared to just the immunotherapy alone. But the combined treatments did have a significant increase compared to the untreated mice, which the dual immunotherapies did not. So again, the statistical power of this part needs more investigating into. So to summarize all of that, we found that 2 gray times 5 fractions significantly increases the tumour vasculature and the oxygen saturation in tumours, and importantly, in the middle of tumours became highly vascularized and even had a higher percentage of vasculature than other parts of the tumour. The combination of radiotherapy and immunotherapy does improve treatment response, and this is most effective when the treatments are given together and also with the addition of anti-CTLA-4. And all of the mice that were cured and then were rechallenged, they resisted secondary growth, sort of regardless of which treatment group they were actually in. But more investigation is needed into the black mice, that they are more resistant. So I'd like to say thank you to my supervisors as well, but also everyone else who has helped with my thesis. It's been 4 and a bit years. So thank you to everybody who's put in a lot of time and effort.
Thanks, Beck. Does anyone have any questions for Beck? Mania?
Yes, I do have a question. Very excellent presentation, Rebecca.
Thanks.
So it's very interesting to see the combination of the immunotherapy and the radiotherapy. I have questions. It's not like a question. It's just like maybe more interested to know. Did you have any chance to monitor the dose to organ at risk or nearby organs, or like combination of this technique you're using? It is better than radiotherapy, or both of them will reduce the organ at risk, or you didn't have a chance to look at the organ at risk dose? Or
Yeah, so they were like subcutaneous tumors, so they're little balls sort of like on the waist. So we couldn't really, there wasn't really many organs at risk, but during the dose planning for radiation, we could see, if there was any dose to sort of like the hips or something, but we couldn't really, like sort of see what was actually getting directly to those organs at risk. But from the treatment plans, it seems like we did sort of arrange the mouse and position it so that was very minimal dose that was going to mostly like the pelvis was and the spinal cord were the main organs, but we arranged it so that they got as little dose as we possibly could. But we didn't actually see it. We saw no side effects from the mice.
Cool. So for the immunotherapy, did you do it through the intravenous or straight to the tumor?
So we did it intraperitoneally.
Okay.
So sort of injected it sort of into the stomach region.
All right. And most of it went to the tumor. Didn't most of it absorbed by the stomach, isn't it?
Well, so yeah, you try and you kind of flip the mouse upside down, like at an angle. So most of it would sort of get into that space. So we try and avoid the stomach and the bladder, and you can kind of feel the difference. So we hope most of it got into the
That's
tumor.
very interesting. Yes, because most like investigator, they have a problem. Most of it goes to the stomach or to the liver. So if you have it like went to the tumor, that's a very good win. Yes. Excellent project, and I enjoyed it. All the best.
Thank you.
Any other questions for Beck? Okay, Jake.
Yeah. Hey, Beck. Really great work there. I was just wondering, so you mentioned that there might have been sort of sample size issues, which explain why there wasn't a significant difference for the combination group. I was just wondering if there were any statistical power calculations that were done before the study, and or if you know what sort of sample size would be required, I guess, to show the significance there.
Yeah, so we did the sample size calculations before, and we had aimed for 10, but still using the statistical power and all the previous people at NCARD, with 7 mice, you can still get pretty good significance. I can't remember the exact numbers. It's 80% with a 20% deviation for my thesis. But so it was still still significant, still statistically significant. It still has that power, but just when you look at it automatically, you kind of think, what? How is that not? But it still does hold that power, just a little bit less than what we had with 10 mice. But definitely the black mice were lacking some significance with that. But
cool. Thanks, Beck.
Okay. If there are no more questions, I'll just thank Rebecca for a terrific presentation. Excellent work over the last, we won't count how many years, you've just mentioned them. And wish you all the best for the examination and the viva and whatever's to come. And I'll stop recording.